every 40 seconds, someone in the United States has a heart attack. 805,000 people a year. Most will feel it in the chest. Some will feel almost nothing. And a great many will spend the most important 20 minutes of their lives deciding whether they're overreacting. Almost everything the public believes about this comes from film. A man clutches his chest and falls. That version is real, and for an enormous number of people, it's the wrong thing to be waiting for. So what's happening inside the artery, minute by minute? What the symptoms actually look like, including one word a major cardiology guideline has ordered doctors to stop using. What to do in the first 10 minutes, in the right order, and what happens after, which is more hopeful than most people expect. Every number comes from a national health agency or peer-reviewed research. First, one distinction, because the public collapses these two constantly, and they need opposite responses. A heart attack is a plumbing problem. An artery feeding the heart muscle gets blocked, and the muscle downstream starts to starve. In most cases, the heart keeps beating the whole time. The person is usually awake and usually talking. Cardiac arrest is an electrical problem. The rhythm fails, the pump stops, the person collapses within seconds. Untreated, death follows in minutes. Most heart attacks don't cause cardiac arrest, but when cardiac arrest happens, a heart attack is one of the most common reasons behind it. Everything from here is about the first one. So what's actually happening in there? Your heart is a muscle, and like every muscle, it needs constant oxygen. It gets it through the coronary arteries, vessels roughly the width of a drinking straw, wrapped around the outside of the heart. Over years, sometimes decades, a waxy material called plaque builds up inside them. That's atherosclerosis. It is silent. It produces no symptoms at all while it's happening. Then, one day, an area of plaque tears open. The body treats that tear like any other wound. It forms a clot. Inside a tube, the width of a straw. Grow it large enough, and blood flow stops. Now the clock starts. And this is the part that usually gets described vaguely, so let's be specific. A heart muscle doesn't die all at once. It dies in a wave, moving from the inner wall of the heart outward. In the experiments that established this, at 40 minutes of blocked flow, roughly 38% of the affected wall had died. At 3 hours, 57%. At 6 hours, 71. At 24, 85. That's an animal model, and human hearts vary. But it's why modern cardiology is built around speed. Now read it backwards, because that's the useful direction. At 3 hours, there was still living, salvageable muscle in there. The wave is not instant. It just doesn't stop on its own. This is a myocardial infarction, a heart attack. Now, all of that can happen with the crushing chest pain you're expecting. It can also happen while someone finishes a shift, drives home, and goes to bed. That second version is where a large share of the preventable deaths come from. Hold on to it. So, what does a heart attack actually feel like? Start with the rule, because a lot of well-meaning health content now overcorrects and skips it. The most common symptom is pain or discomfort in the center or left side of the chest. True for men, equally true for women. The American Heart Association is explicit that chest discomfort is women's most common heart attack symptom too. Pressure, squeezing, fullness, heaviness, a weight. It may last more than a few minutes or fade and come back. That's the rule. Here's the range. The discomfort doesn't stay put. It can appear in one or both arms, the back, shoulders, neck, jaw, or just above the belly button. In fact, when cardiologists write chest pain in a guideline, the clinical definition includes all of those places. A lot of public confusion lives in the gap between the medical phrase and the everyday one. There may be shortness of breath, with or without chest discomfort, more common in older adults. Heavy sweating for no reason, nausea, sudden lightheadedness, a heartbeat that races or beats irregularly, and unusual, unexplained exhaustion, sometimes building over days. That one is more commonly reported by women. One more thing the agencies state plainly. Symptoms can start slowly, stay mild, come and go over hours. They vary from person to person, and if you've had one before, the second may not feel like the first. Which brings us to a word. For decades, presentations that didn't match the textbook got filed under one label, atypical, and it was applied disproportionately to women. In 2021, America's major cardiology bodies published a chest pain guideline containing an unusually blunt instruction, a Class 1 recommendation, their strongest category, that clinicians should not describe chest pain as atypical. The stated reason? It doesn't help determine the cause, and it has been misinterpreted as meaning benign. A word formally retired because of what believing it did to people. Here's the data underneath it. Among 1,941 patients with suspected acute coronary syndrome, chest pain was reported by 92% of the women and 91% of the men. And among those confirmed to be having a heart attack, the women were more likely than the men to present typically, 77% against 59%. So the popular correction, women don't get chest pain, women get something else, isn't a correction. It's a distortion, and it points people away from what they're most likely to feel. What's true is that women more often have additional symptoms alongside the chest discomfort. Widen the picture. Don't delete its center. Now the part that should bother you. In 2009, 65% of American women correctly named heart disease as the leading cause of death in women. By 2019, 44%. And it didn't fall evenly. The steepest drop was among women aged 25 to 34, an 81% decline. The youngest group going backwards fastest. Earlier, I told you to hold on to something. Here it is. Some heart attacks produce no symptoms at all, or symptoms so mild nobody connects them to their heart. Silent heart attacks. And here, two credible sources hand you two different numbers. The CDC says about 1 in 5 heart attacks are silent. The damage is done, the person doesn't know. But a community study that put nearly 10,000 adults through repeated ECG screening, actively looking rather than waiting for anyone to report anything, found silent heart attacks made up 45% of all heart attacks in that group. 1 in 5, or nearly half. Both are honest. The gap is the point. The CDC figure counts heart attacks that get recognized. The screening figure counts heart attacks that happened. When you go looking, you find more. And silent doesn't mean harmless. In that same study, people whose heart attacks went unrecognized had roughly 3 times the risk of dying of heart disease. Other follow-up links them to later heart failure. The muscle doesn't care whether you noticed. They're more common in older adults and people with diabetes. And when there are symptoms, they're the kind nobody takes to an emergency room. Something like flu, a strained muscle, an ache in the jaw, indigestion, being very, very tired. So how do you tell serious from ordinary? One distinction is genuinely useful. Angina, pain from a narrowed artery, usually comes with exertion and eases within minutes with rest or medication. Heart attack pain is more serious, and it does not go away with rest or medication. That's a reason to call. It is not a test to run on yourself while a clock is ticking. Unsure means call. Quick detour, because this one surprised me. Swedish researchers examined 283,000 heart attacks across 16 years and asked whether the calendar matters. It does. Christmas Eve carried 37% higher risk, peaking around 10 at night. Christmas Day, 15%. Midsummer, 12%. Early mornings and Mondays were elevated. Easter showed nothing. Sporting events showed nothing. It's observational, a pattern, not a proven cause. The effect was strongest in people over 75 and those with diabetes or existing heart disease. Worth knowing whose Christmas Eve to pay attention on. Back to the belief that quietly costs more lives than anything on the symptom list. That's not me. Risk does climb with age. For men after 45, for women after 55 or after menopause. That matches the stereotype. Here's what doesn't. In United States community surveillance, the share of heart attack hospitalizations in adults aged 35 to 54 rose from 27% in the late 90s to 32% by 2014, and the sharpest rise was in young women, 21 to 31%. Second, not every heart attack comes from a plaque-filled artery. When one happens without obstructive coronary disease, it's called MINOCA. More common in women, younger people, and Black, Hispanic, and Asian patients. Causes include artery spasm, a traveling clot, and spontaneous coronary artery dissection, a tear in the artery wall, most common in women under 50 and in pregnancy. Third, documented by the American Heart Association itself in a scientific statement published in 2026. Women having heart attacks are less likely to be triaged as emergencies, less likely to receive catheterization, less likely to leave hospital on the recommended medications, and they die at higher rates than men of the same age. Some of that gap opens before the hospital. In patients 55 and under, women took a median 3.2 hours to arrive, against 2.4 for men. Some opens inside it. In one emergency department study, women waited 48 minutes to be seen. Men, 37. So, someone near you, or you, has symptoms that fit. What now? 1. Call 911, even if you're not sure. Dispatchers and paramedics can begin advice and treatment that limits heart damage, and you are not wasting anyone's time. About 6.5 million people a year arrive at American emergency departments with chest pain, and only around 5% turn out to be an acute coronary event. The system is built for that ratio. It expects you. 2. Do not drive and do not be driven. This is the instruction people override most, and it's where the evidence is most one-sided. An ambulance isn't slower transport, it's earlier treatment. Paramedics can assess you, run an ECG, and start medication before you reach the building, and ambulance arrivals are often treated faster. They can also restart a heart that has stopped. A passenger seat cannot. 3. Aspirin, where the order matters more than the pill. From American Heart Association and Red Cross First Aid Guidance, after emergency services have been activated, a first aid provider may encourage an alert adult with non-traumatic chest pain to chew and swallow 162 to 324 milligrams of aspirin, unless they have an aspirin allergy or a doctor has told them not to. Earlier aspirin was associated with better 7-day and 30-day survival, with no significant rise in complications. So it's genuinely useful. It's simply second. Call first, and never delay the call hunting for a tablet. 4. Ignore cough CPR. The version circulating online is not endorsed by the American Heart Association and shouldn't be taught to lay rescuers. It has no role outside a hospital, and someone who has already collapsed can't cough on command. And if a person becomes unresponsive and stops breathing normally, that's no longer a heart attack in progress. That's cardiac arrest, and it needs CPR immediately. Over 70% of these happen at home, which means the person doing compressions is usually family. Earlier, I said the clock had started. Here's the other side of it. The first test is an electrocardiogram, often within minutes, sometimes in the ambulance. Guidelines call for it to be recorded and read within 10 minutes of first contact with medical staff. That single trace splits the diagnosis. STEMI means completely blocked. NSTEMI, partially. Both urgent, treated differently. Then blood. When heart muscle cells die, they release a protein called troponin. Measuring it, and repeating the measurement to see which way it's moving, tells the team whether muscle is being lost, and roughly how much. For women of childbearing age, a pregnancy test is part of the workup, because it changes what's safe to use. Then the artery has to be opened. The main procedure is percutaneous coronary intervention, a catheter threaded to the heart, a balloon inflated at the blockage, and usually a small mesh stent left behind to hold it open. For more extensive disease, surgeons can bypass the blocked section. Where a hospital can't reach the artery in time, clot-dissolving drugs are used. And here's the number that makes every earlier minute count. For a suspected STEMI, the system-wide target is to get that artery open within 90 minutes of first medical contact. 90 minutes. And that clock starts when the paramedics reach you, not when you decide to call, which means the only part anyone can lose is the part before the phone call. So that's the emergency. Now the ordinary day, when nothing is going wrong. First, reassurance. Earned, not offered. Most people survive heart attacks and go on to live full, active lives. In 1970, someone over 65 hospitalized with a heart attack had roughly a 60% chance of leaving alive. Today, it's over 90. Across that same period, the share of deaths caused by heart attacks fell by nearly 90%. Recovery has a name: cardiac rehabilitation. Supervised exercise, education, counseling. It improves quality of life, lowers the chance of returning to hospital, and helps prevent the next event. And Medicare and most insurers cover 36 sessions over 12 weeks. It's also the thing most people skip. Among eligible Medicare patients, only about a quarter took part at all, and barely a quarter of those finished. Participation was lower among women. If it's offered to you or someone you love, go. As for prevention, the honest version. A study across 52 countries found 9 modifiable factors: cholesterol, smoking, blood pressure, diabetes, abdominal obesity, stress, diet, alcohol, inactivity. Together, they accounted for around 90% of the population-level risk of a first heart attack. The CDC estimates 80% of premature heart disease and stroke is preventable. Read those carefully, because they get misused. They describe what could be avoided across a population. They are not a personal guarantee. Age and family history can't be changed. Mechanisms like SCAD aren't lifestyle-driven at all. Fit, young, non-smoking people do have heart attacks. What prevention does is shift the odds, substantially, in your favor. No single food is a shield. The combination, sustained over years, is the closest thing that exists. If you remember nothing else, remember 5 things. 1. Chest discomfort is the most common sign, in men and in women. 2. It can also arrive as breathlessness, jaw, neck, back or arm pain, cold sweat, nausea, or an exhaustion that doesn't fit the day. 3. Pain that eases with rest is different from pain that doesn't, and being unsure is already a reason to call. 4. Call first. Don't drive. Aspirin comes after the call, and only if it's safe for that person. 5. 90 minutes is the target once the system has you. The only part you can lose is the part before you pick up the phone. We opened with a number: 805,000 a year, 1 every 40 seconds. Numbers that size make this feel like weather, something that either happens to you or doesn't. It isn't weather. Almost everything that decides the outcome happens between the first symptom and the first phone call. And that gap doesn't belong to a hospital. It belongs to a person, standing in a kitchen, deciding whether they're making a fuss. The heart is patient. It will absorb decades of quiet damage without complaint. It just can't absorb an afternoon of waiting. If one person came to mind while you were watching, send this to them. That's the only ask. This is educational, and it is not medical advice. If you think you or someone near you is having a heart attack, stop watching and call your local emergency number now. In the United States, that's 911. Every source is linked below.